Imagine walking into a clinic on your lunch break, and in less time than it takes to order a coffee, like literally 8 seconds to be exact, a doctor uses a dermal filler originally designed for your cheeks to completely alter your internal anatomy.
Yeah, it's wild. It entirely rewrites your physical sexual response.
Right. Welcome to the new frontier of intimate wellness.
It really is a frontier. I mean, it completely redefines the medical baseline we're used to. We're moving away from that traditional model of, purely reactive disease management.
Where the only goal is basically just fixing something that's broken.
Exactly. Instead, we're looking at this highly individualized, proactive physiological enhancement.
Okay, so let's unpack this. Welcome to your deep dive. We have this really dense stack of clinical sources, aesthetic guidelines, and even public health data to analyze for you today.
It's a lot of material, but it paints such a clear picture.
It really does. Our mission here is to explore this rapidly evolving, honestly highly specialized landscape of intimate medicine. Specifically, we're examining how facial cosmetic techniques have migrated south to the pelvic region for female sexual rejuvenation.
The technology transfer is just fascinating.
And we are zeroing in on one highly specific clinical question today. Can a G-shot be combined with labial puff augmentation in a single treatment session?
And to answer that, we're definitely going to look at the underlying biology of why patients and doctors are pushing for these specific combinations.
But true intimate health isn't just about the aesthetics or functional enhancement.
Well, no, not at all. You can't ignore the disease management side of things.
Which is exactly why in the second half of this deep dive, we're going to examine the biological defense of that exact same tissue. We are pulling from this massive public health data set out of Canada to see how frontline doctors are utilizing complex dual drug therapies to battle antimicrobial resistant infections.
It's the full spectrum of taking ownership of your body, really, from maximizing pleasure to rigorous disease management.
Yeah, but let's start with the aesthetics today, because to really understand the mechanics of modern injectables, we kind of have to look at the surgical foundation they were built on, right?
We do. The sources detail the medical context of female genital plastic surgery, or FGPS.
Right.
For a long time, if a patient wanted structural changes to their intimate anatomy, surgery was literally the only mechanism available to them.
And the clinical turning point that the sources highlight is this landmark 2010 multi-center study. It was published in the Journal of Sexual Medicine by Goodman and colleagues.
Yeah, and this wasn't just like a small survey. It provided really objective, utilizable outcome data across multiple clinics.
They tracked 258 women.
Right.
Who underwent a total of 341 separate surgical procedures.
Exactly. The researchers were looking at structural modifications, so tissue reductions, realignments, things like that. And the longitudinal data they captured is vital.
So what did they actually find?
Well, after a follow-up period ranging from 6 to 42 months, the objective metrics showed a 91.6% satisfaction rate.
Wow, over 91%, that's huge.
It is. And more importantly, the study documented a statistically significant enhancement in sexual functioning for both the patients and their partners.
Now, the researchers explicitly state in the methodology that these procedures were not performed to correct abnormalities. They acknowledge this vast range of anatomical normal.
Right, there's no single normal here.
Exactly. So these surgeries were elective enhancements based entirely on patient desire. It's like getting a haircut or coloring your hair. It's not about fixing a disease. It's about personal preference and confidence. But I do have to push back a little on this 91% satisfaction rate in the context of what clinics are doing today.
Oh, sure.
Because if surgery was so permanently effective, giving patients a long-term structural fix, why are we seeing this massive industry shift toward temporary non-surgical injectables?
That's the big question.
Like injectables dissolve. Why are patients opting for a temporary subscription model for their own bodies?
Well, what's fascinating here is that the shift comes down to the physiological cost of surgical intervention. Surgery, no matter how successful the aesthetic outcome is, triggers a severe inflammatory cascade.
Right. Your body is literally traumatized.
Exactly. You're dealing with general anesthesia, incisions through highly vascularized mucosal tissue, the risk of nerve damage, and the formation of scar tissue, which can unpredictably alter sensation.
So the 91% satisfaction is great, But the barrier to entry, like the weeks of downtime and all those surgical risks, just way too high for the average person.
Precisely. While surgeries like labiaplasty are definitely still popular, modern patients want the anatomical enhancement without that inflammatory cascade.
They want the results without the recovery.
Right. They're demanding what the industry calls lunch break procedures. The appeal of a temporary injectable isn't that it fades, it's that it requires zero physiological downtime.
You alter the tissue architecture and immediately go back to the office.
Literally, you return to your normal routine the same day.
Which brings us to the internal functional enhancement, detailed in the clinical sources, the G-shot, or G-spot amplification.
Yeah.
I really want to get into the biological mechanisms here because the process is just fascinating.
It is.
We're talking about injecting a dermal filler directly into the anterior vaginal wall.
Yeah, so the target is the front wall of the vaginal canal, typically located about 4 to 5 centimeters inside.
Okay.
The goal is to physically expand the tissue of the G-spot erogenous zone. They're basically altering its topographical profile so it projects further into the canal.
And the clinics use a few different materials for this, right? The sources mentioned they utilize collagen, a patient's own purified fat, or hyaluronic acid, which is that same compound found in facial fillers like Juvederm.
That's right. HA is incredibly versatile.
But mechanically speaking, how is hyaluronic acid achieving this expansion in mucosal tissue? Is it just like taking up space like a physical lump?
No, it does so much more than just take up space. Hyaluronic acid is a naturally occurring glycosaminoglycan. Its primary biological function is to act as a humectant.
A humectant. So it draws in moisture.
Exactly. Once injected into the anterior wall, it acts like a microscopic sponge, drawing in and binding to water molecules. This creates a really localized swelling.
Okay, so it's not just the filler itself, it's the water it attracts.
Right. The sources describe the physical augmentation as expanding the zone to about the size of a quarter in width and projecting about 1/4 of an inch in height.
So you're creating a distinct, localized structure that is just structurally much easier to stimulate during intimacy. And the application process is stunningly fast.
It's incredibly quick.
Yeah, the sources note that after applying a topical or local anesthetic, the actual injection takes less than 8 seconds. But from a clinical standpoint, considering how widely the anatomical location of the G-spot varies from person to person...
Oh, it varies wildly.
Right. So how does the doctor even know where to inject in that tiny window of time?
Well, the 8-second window is just the delivery mechanism. The actual targeting relies on highly collaborative tissue mapping before the needle even comes out. Oh, okay, so they're not just guessing.
No, definitely not. The sources outline a protocol where the patient performs a self-examination simultaneously with the doctor's pelvic exam.
Oh, wow.
Yeah, they systematically palpate the anterior wall to isolate the precise coordinates that elicit the highest arousal response.
Okay, so they map it out together.
Exactly. Only after they have locked in that exact physiological target is the speculum placed to expose the tissue for that rapid injection.
That is such a highly customized approach. And I guess the lifespan of this structural change really depends on the material used.
It does. Collagen provides about 4 months of expansion.
But if they use a hyaluronic acid filler specifically formulated for this denser tissue, like Deserial, the biological scaffolding holds for anywhere from 9 to 12 months, right?
Right, before the body's natural enzymes eventually metabolize it.
It's crazy to think about.
And, the origin of this technique actually highlights how deeply interconnected functional medicine and aesthetic enhancement are.
Oh, right. The history of this is super interesting. Yeah, these transvaginal collagen injections, they were not invented for sexual pleasure.
Wait, really? What were they for?
They were originally developed as a functional treatment for intrinsic sphincter deficiency, which causes severe urinary incontinence in elderly women.
Oh, wow. So they were using the filler as a bulking agent to physically prop up and support the urethra to stop urine leakage.
Yes, but by structurally bulking that specific anatomical region, the medical community observed an off-label side effect.
Let me guess, the incidental amplification of the G-spot.
Exactly. The technique was subsequently co-opted and refined entirely for sexual enhancement.
That is wild. Okay, so that covers the internal functional manipulation. But to get to the core focus of the deep dive you're listening to today, we have to look at the external cosmetic side too.
Right, we have to look at the whole picture.
The sources introduce a procedure known as the labial puff, or labial augmentation.
Right, because over time, factors like cellular aging, localized fat depletion from weight fluctuations, or even the structural stress of childbirth, all of that can cause the outer lips, the labia majora, to lose its foundational volume.
So the skin basically becomes deflated or lax.
Exactly. Labial puffing is simply the clinical process of restoring that lost architectural volume.
And the sources outline two primary mechanisms for this. The first is using those exact same hyaluronic acid dermal fillers we just discussed, drawing in water to plump the tissue for like 12 to 18 months.
Right.
But the second method is autologous fat transfer. This involves the doctor performing a localized mini liposuction, usually harvesting adipose tissue from the patient's abdomen or thighs.
Yeah, they run that tissue through a centrifuge to purify it and then inject those fat cells into the labia majora.
Autologous fat transfer leverages the patient's own biological material, right?
Right.
Which obviously eliminates the risk of an allergic immune response.
Exactly. And it also offers a much more permanent structural integration compared to the temporary water binding action of hyaluronic acid.
You know, a lot of people describe fat grafting as like rearranging the furniture in your house, moving the couch from the living room to the den where it looks a little better.
It's a funny way to put it, yeah.
But biologically, it's not just moving inert volume, is it? It seems more like transplanting a tree. You have to carefully uproot the living fat cells, purify them, and plant them in the labial tissue where they have to establish a brand new blood supply to actually survive.
That is the exact biological hurdle, yes. It's a process called angiogenesis.
Angiogenesis.
Right. The transferred fat cells must stimulate the growth of new blood vessels in the labia majora to receive oxygen and nutrients. If they don't vascularize, the body simply reabsorbs the dead cells.
Oh, so it just disappears.
Pretty much.
Yeah.
This is why the centrifugation process is so absolutely critical. It isolates the healthiest, most viable fat cells to ensure the highest survival rate in that new tissue bed.
Okay, which finally brings us to the central question of our deep dive. Here's where it gets really interesting. We have the internal G-shot utilizing HA to amplify functional pleasure. And we have the external labial puff utilizing HA or transplanted fat to restore cosmetic volume. Can a patient walk into a clinic and receive a G-shot and a labial puff in a single combined treatment session?
Analyzing the clinical protocols across our sources, the answer is definitively yes.
Okay, so they can absolutely be stacked.
Yes. The aesthetic medical literature clearly states that patients frequently combine labial puffing with other vaginal rejuvenation treatments to achieve what clinics term cohesive and comprehensive results.
So stacking these procedures is basically standard protocol at this point.
It is totally the industry norm. Furthermore, the data shows G-shots are regularly stacked with other regenerative therapies too, such as platelet-rich plasma or PRP injections.
Oh, like the O-shot.
Exactly. Those utilize growth factors from the patient's own blood to stimulate cellular turnover. Executing all of these non-surgical, minimally invasive injections in one single session is an entirely standard clinical practice for a complete intimate makeover.
But from a clinical and psychological perspective, why is stacking these specific procedures the preferred approach? Why not space them out?
It maximizes the clinical intervention window. Because both the G-shot and the labial puff are non-surgical and rely entirely on local anesthetics, they completely bypass the systemic trauma of surgery we discussed earlier.
Right, no inflammatory cascade.
Precisely. A patient can utilize a single clinic visit to address functional, internal pleasure and aesthetic, external volume simultaneously.
And the physiological downtime remains virtually zero.
That's the key. They receive a comprehensive anatomical update and get back to normal activities within just a few hours.
Incredible. Well, we spent this time examining how clinics structurally manipulate mucosal tissue for pleasure and aesthetics. But the health of that exact same tissue is also the frontline immune barrier against disease.
It is.
So we're going to make a hard pivot here to look at the biological defense of intimate anatomy. Because taking control of your intimate health isn't just about maximizing pleasure and aesthetics. It's also about rigorous medical care and disease management.
This is such a critical transition. You cannot maintain intimate wellness if the foundational health of the tissue is compromised by pathogenic infection.
Exactly. And the sources provide a rigorous public health data set from Canada's Enhanced Surveillance of Antimicrobial-Resistant Gonorrhea System, which is known as ESAG.
Yes, the ESAG data.
This data, collected between 2018 and 2024, tracks 4,885 cases. Yeah. And they aren't just tracking infection rates, right? They're actually measuring how strictly frontline doctors are adhering to complex treatment guidelines.
Because they're monitoring a literal evolutionary arms race here. Neisseria gonorrhoeae is a highly mutable bacterium.
Meaning it adapts quickly.
Very quickly. It rapidly develops genetic resistance to single drug antibiotic treatments. Public health officials are tracking whether doctors are utilizing the required biochemical strategies to outsmart the pathogen's mutation rate.
And the data categorizes these 4,885 cases by demographic, separating GBMSM, which stands for gay, bisexual, and other men who have sex with men, from other adults, which encompasses heterosexual males and all females.
Right, they break it down thoroughly.
And they also track the anatomical site of the infection, comparing anogenital infections against pharyngeal or throat infections.
But regardless of the demographic or the infection site, the recommended medical defense is highly, highly specific.
What's the protocol?
To overcome the antimicrobial resistance, the protocol dictates a dual drug therapy. Doctors must prescribe a cephalosporin, either ceftriaxone 250 milligrams or cefixime 800 milligrams simultaneously with a macrolide, specifically a 1-gram dose of azithromycin.
Okay, looking at the ESAG compliance data, they are aggressively pushing this exact dual drug combination. I assume this isn't just about hitting the infection with a heavier dose of medication, though. This sounds like a deliberate biochemical crossfire to trap the bacteria.
That is the exact mechanism of action, yes. You are attacking the bacterium's survival infrastructure from two completely different biological vectors.
How does that work?
While the ceftriaxone targets the bacterial cell wall, inhibiting the enzymes needed to maintain its structural integrity, it effectively causes the cell to rupture.
Wow, okay. And the azithromycin?
The azithromycin penetrates the cell and attacks the ribosomes, completely shutting down the bacterium's ability to synthesize proteins.
Oh, I see. So even if a specific strain has somehow mutated a genetic defense against the cell wall attack, it gets wiped out by the protein synthesis shutdown before it can even replicate and pass on that resistance.
Exactly. The dual therapy strategy is designed to ensure a 100% eradication rate within the host, leaving absolutely no surviving resistant bacteria to spread through the population.
But wait, so what does this all mean for the patient? When we look at the actual adherence numbers in the ESAG charts, the proportion of cases where doctors actually prescribe this preferred dual therapy hovers around the 80% to 90% mark across all demographics and infection sites.
Right, it fluctuated a bit.
Yeah, spiking to 95% in some years and dipping to 81% in others. If this dual therapy crossfire is the definitive frontline defense against a resistant superbug, why are 10 to 20% of patients receiving a non-recommended treatment? Why isn't it 100%?
Oh, the gap between 90% and 100% adherence just reflects the friction of real-world clinical practice.
What do you mean?
The guidelines dictate the ideal biological strategy, but doctors have to treat the actual patient sitting in front of them. For example, a patient might have a documented anaphylactic allergy to cephalosporins.
Oh, right. So they literally can't take the primary drug.
Exactly, which forces the doctor to utilize a less optimal alternative antibiotic therapy.
And the sources also mention external logistical factors like supply chain disruptions.
Yes, that's a huge factor. There were documented regional shortages of ceftriaxone during this surveillance period. I mean, a doctor cannot prescribe a drug that isn't physically in the pharmacy.
Right, that makes total sense.
Furthermore, pharyngeal infections, those in the throat, are notoriously harder to eradicate than anogenital infections due to the differing mucosal environment and blood flow. Doctors sometimes have to adjust dosages or therapies based on localized treatment failures.
So an 80% to 90% compliance rate isn't evidence of doctors just, ignoring the guidelines. It actually represents an incredibly strong, unified medical front adapting to real-world biological and logistical constraints while still holding the line against a superbug.
It really is a massive public health triumph. The surveillance infrastructure is successfully guiding thousands of independent clinical decisions to protect the broader population's tissue health.
This deep dive honestly highlights a fascinating duality in modern medicine. In the first half, we explored the aesthetic side, the G-shots and labial puffs. That environment is highly customized, it's driven entirely by patient desire, and it utilizes off-label applications of dermal fillers to achieve a personal architectural goal.
Right. It is the ultimate expression of individualized proactive wellness.
But then we look at the ESAG data, which represents a highly rigid, centrally monitored, guideline-driven landscape designed to protect the public at large from mutating pathogens. They seem like completely opposed medical philosophies, yet they are both focused on the exact same anatomical structures.
They represent the dual responsibilities of taking ownership of your body, You have the agency to pursue functional pleasure and aesthetic confidence, but that agency is built on a foundation of rigorous, evidence-based disease prevention.
You can't really have one without the other.
Exactly. You cannot have the cosmetic enhancements without the biological defense.
It's a complex landscape to navigate, but understanding the mechanisms behind these treatments is really the key to empowerment. Let's just quickly recap the clinical journey we've mapped out for you today.
Sure.
We started by examining the surgical foundations of intimate aesthetics, realizing that while 2010 surgical data showed a 91% satisfaction rate, the heavy physiological cost drove the market toward non-surgical alternatives.
Right, the lunch break procedures. We detailed how hyaluronic acid mechanically functions as a humectant, allowing doctors to precisely expand the internal G-spot in an 8-second injection window.
We looked at the biological hurdle of angiogenesis in autologous fat transfers for labial puffing, and we answered our core focus question. Clinical protocols absolutely support stacking both the G-shot and the labial puff in a single, zero downtime session to achieve cohesive internal and external results.
A total intimate makeover in one visit.
Exactly. Finally, we analyzed the ESAG data, breaking down the biochemical crossfire of dual drug therapies used to defend this tissue against antimicrobial-resistant gonorrhea, maintaining an impressive 80% to 90% clinical compliance rate over 6 years.
It's a testament to the incredible adaptability of both the human body and modern clinical practice.
For you listening to this deep dive, the underlying message is that the taboos surrounding intimate health is rapidly dissolving in the face of advanced science. Whether you're seeking to structurally enhance your personal pleasure, you're exploring cosmetic restorations post-childbirth, or simply staying informed on the public health protocols protecting your baseline health, understanding the why and the how gives you the authority to make informed decisions.
And as we close this deep dive, I want to leave you with a final thought regarding the trajectory of this medical frontier.
Oh, definitely.
We've seen how facial fillers have been successfully repurposed for the pelvic region, shifting the paradigm from surgical correction to temporary injectable enhancement.
Right.
But as regenerative medicine continues to rapidly evolve, specifically therapies involving advanced stem cell harvesting and hyperconcentrated PRP, we are moving toward treatments that don't just temporarily plump tissue, but actually reverse cellular aging at a structural level.
The science is accelerating exponentially. It's almost hard to keep up.
It is, and it raises a profound question for you to consider. In the next decade, as these regenerative technologies become cheaper and faster, will intimate biological enhancements become as casually integrated into our routines as dental cleanings or skincare regimens?
Like getting Botox or highlights in your hair.
Exactly. And if structurally reversing the clock on intimate tissue becomes the new, easily accessible baseline, how will that completely redefine our cultural expectations and our psychological relationship with sexual aging?
That is an incredible concept to mull over. If we are already rewriting the baseline in an 8-second clinic visit today, the landscape in 10 years will be completely unrecognizable. Thank you for joining us on this deep dive. We hope you take these mechanisms, keep analyzing the data, keep challenging the baselines, and keep exploring the incredible science behind your own health. Until next time.